I'm delighted to introduce to you Courtney Munro, who is a pharmacist and a candidate for the Doctor of Philosophy degree with the Department of Paediatrics at the University of Melbourne. She is undertaking her PhD at Melbourne Children's, studying biomarkers of aminoglycoside nephrotoxicity. Now, I had no idea what that meant when I first read it, but Courtney has told me that it's looking at the toxic effects of drugs on the kidneys. And that's an area of study that she's involved in with young children with cystic fibrosis. Her research interests are cystic fibrosis, acute kidney injury, chronic kidney disease, and pharmacogenomics. And I'm sure that we'll understand what that means at the end of today's session as well. She is a sessional teaching associate at Monash University, Faculty of Pharmacy and Pharmaceutical Sciences for both undergraduate and postgraduate students. She also leads the Pharmacists Special Interest Group. Ladies and gentlemen, please welcome Courtney Munro.
Thank you to Nigel for his very kind introduction and for learning some of those difficult words and terms. The pharmacogenomics, which is probably the hardest one to pronounce aside from pharmacokinetics, which I'm talking about on Monday, is the way in which medicines and genes interact. And so a great example of pharmacogenomics is actually ivacaftor, and that's the way in which the drug has been designed to treat the gene defect, and that's an area of interest of mine. So we'll begin today's presentation. So I have been a pharmacist at the Royal Children's Hospital from 2008, and I'd always worked in paediatrics. More recently, I have commenced a PhD with the University of Melbourne, and we're having a look at the best way to use antibiotics, and we're looking at the side effects that antibiotics may have on the kidney and whether or not we can measure that better by having a look at some markers in the urine. So what are we going to talk about today? I've tried to cover a range of things. The first thing I'm going to do is illustrate a pharmacist dictionary. And you probably say, why? Those terms are quite difficult. And I will try and use lay terms, but this is more if you're reading material so that you can know what we're actually talking about, what we mean. We'll then talk about whether or not children are special or different with regard to drugs. A little bit about paediatric pharmacokinetics. Now, that's just the way in which kids handle drugs, so don't be frightened by the word. How medicines are prescribed for children and how they're given to children. We'll then talk about common medicines used in CF. I'll cover a little bit about adverse drug reactions, so side effects. Briefly, we'll look at complementary and alternative medicines and where you can find more information. So the first thing I have to go through is a pharmacist dictionary. So we might say indication, but what we actually mean is why are we using the medicine? What is its purpose? Okay? And so if you're reading material, you may see the word indication. The other thing we talk about is mechanism of action, which is how it works, so what it does. Okay? Adverse effect translates to side effect. That's fairly simple. It's a reasonable translation. Drugs also have interactions. When we talk about drug interactions, we generally mean drug-drug interactions. So that's when you use two drugs together and you get an unexpected occurrence. But sometimes we talk about drug-food interactions. Now, for most of you who might be parents in the audience, the biggest one that you've probably encountered is ciprofloxacin and dairy, or ciprofloxacin and food. So that's what we mean about a drug-food interaction. And then in some cases, there can be what we call drug-condition interactions. So in certain conditions, we might not want to use that medication or drug because it could make things worse. So that's what we mean by drug interactions. The dose form is how the medicine comes. Is it a tablet, a capsule, a solution, a suspension, an inhaler, a nebule? How does it come? Frequency is how often it's taken. Do we use it twice a day? Do we use it 3 times a day? Do we use it 4 times a day? Therapeutic drug monitoring roughly equates to drug levels, and they will usually be taken by a blood level or a blood sample. Okay. The route of administration is how the medicine is given. So do we give it by mouth? Do we give it by inhalation? Do we give it by a nebulizer? Adverse effects roughly translate to side effects or reactions that might occur when using a medicine. And pharmacokinetics, which is the big scary word, is the way in which the body absorbs the drug, distributes the drug around the body, and the way in which it gets rid of the drug. Now, drugs are gotten rid of in one of 2 ways. They're gotten rid of by the liver or the kidney, okay? So we call that hepatic, being liver, and kidney is renal. So they're cleared one of 2 ways. Some drugs are cleared a little bit of both. And oral is by mouth, so that's probably the most simple. Now, for the purposes of this talk, I will use the term medicine and drug interchangeably, so they do mean the same thing, and medicine is the singular and medicines being the plural. Okay. So this brings me to the next slide. Are children special? Yes, they are. They're not small adults. They're not the Tyrion Lannisters and mini-me's of the world, although sometimes they have the attitude. But there are differences in the way in which a child processes medications across the different age groups, and we need to tailor the dosing to their age and to their weight. Some children are proportional, age and weight-wise. Others might be a little bit slighter, and increasingly we're seeing children that might be overweight, and so we need to think about how old they are, but also how heavy they are. We might need to consider the availability of measurable doses and dosing forms. So when I talk about that, is there a liquid available? You've got a 2-year-old and all we've got is this 150 milligram capsule and we want to give them 7 milligrams. And that becomes very difficult. And so that's where the pharmacist comes in terms of manipulating that dose form to make something that can be measured and given. Sometimes we might take that 150 milligram capsule and we might create 10 milligram capsules from it, and that's quite involved in terms of packing it down. But we might need to modify an existing dose form to make it suitable for use. If any of you in the audience are parents, you've probably had experience with crushing tablets. And I sympathise with you, and I also resonate the fact that it's very hard, and the availability of some of these medicines in a liquid form in Australia is certainly inferior to many other countries where access is much easier, and we'll talk about that a little bit more later. So adult dosing is usually standardised, where one size fits all, and adult dosing is usually based on around a 70 kilo adult. The recommended dose for a child can be based on a number of factors. The organs mature as the child develops, so the liver metabolism, so the way in which the liver processes drugs, is usually fairly well developed by about 4 weeks of age. But the way in which they're excreted by the kidney changes significantly. So there's a certain level of maturation where the kidney reaches at about 1, and by the age of about 2 years, the child's kidneys are functioning as an adult kidney would. But in that first 2 years, they're a little bit slower than that. Children tend to have more body water and less body fat, and children with CF tend to handle drugs a little bit differently to children without CF. And when I say handle them differently, they process them very quickly, and because of that we often need to give more or give it more often. When we calculate the dose for children, we base it on their weight, but we also take into account their age. And for some drugs, particularly some of the antiviral drugs and a few of the antibiotics, we calculate on what we call body surface area. And so that's a really complicated calculation where we go, okay, well, how tall are you and how heavy are you? And then we sort of work out how much fluid there is in between. But the principle is that the dosing should never exceed the maximum adult dose. So a good example for that might be paracetamol, where you would never give more than 8 tablets a day to an adult. If you've got a very heavy child and you work it out in milligram per kilo, you still don't give more than you would give to an adult. Okay. When do children become adults? And this is very arbitrary, and you could ask 10 pharmacists and get 10 different answers. But the principle that we try and employ at the children is when the milligram per kilo dose is at the upper end of the adult dose. And a nice arbitrary rule for that is about 15 years and 50 kilos. So if they're 15 years old and they're more than 50 kilos, they can usually handle medicines like an adult could. Okay? If they're 18 years and 35 kilos, they won't. Okay? The dosing that we use for children is derived from very specialist references, and a lot of this is not available on the internet. Now, your pharmacist or your doctor will use resources. We now have, and we're very fortunate, for the Australian Medicines Handbook for Children, which has come out of Adelaide in the last 2 years. But before that, we were exclusively using the Children's Hospital Paediatric Pharmacopoeia. And we also rely heavily on a British book called the British National Formulary and the Paediatric Drug Handbook. So one of those being UK-based and the other being American. The thing that I personally like about the Paediatric Drug Handbook is it's got lots of doses specifically for CF in there. So that's really good. So that's my sort of go-to one if I'm looking for something for CF. Now, you don't need to know about this, but you need to know that the pharmacist has to be looking in the right place. And if you're at the local community pharmacy, I can't tell you how many community pharmacies don't even know that this Australian Medicines Handbook exists. And we are doing our bit to try and disseminate that information across Australia. So we use a specialist text. If you're looking up a dose on the internet, you're unlikely to find the same thing that we're going to find in these books. It's not easy to find information, and a large part of this comes down to marketing. So humans will spend 16 years as a child compared to 60 to 80 years as an adult. And because of that, they're less likely to need medical treatment. This is with the exception of children with chronic illness. It's a relatively small population and it's just not profitable. They also require more expensive dose forms. So believe it or not, to make a liquid or a suspension is actually more expensive than to make a tablet. And the reason for that is because of the freight and the packing involved. So the packaging that the product is in. And mixtures and liquids often have a shorter expiry, so they might have an expiry of 6 or 12 months as opposed to a tablet that could have an expiry up to 5 years on it. So it doesn't make sense for drug companies to develop medicines for children. That said, the regulatory organisations are doing a lot, and there's now discounts offered in Australia to anyone that wants to register a new drug. And they can get a discount on that registration if they've done some studies in children and if they've got an awareness of products that should be suitable for children. So if they've done their bit, there is a concession for them in terms of registering that drug. So I'm going to move on now and talk about paediatric pharmacokinetics, which is what the body does to the drug. And there's 4 stages when the drug's taken in, as to when it leaves the body. At birth, the pH of the stomach is really quite high, and this reaches adult levels by about 2 to 3 years of age. So when I say it's high, it's about 6 to 8, and when it reaches adult levels, it's about 1.8. So neutral pH is about 7.4. So it becomes quite acidic. And what this means is that some medicines are then absorbed quicker because the acid breaks down the coating on the drug and the drug's absorbed much faster. In addition to that, the movement of the medicines through the GI tract, so this is once it's gone out of the tummy and it's in the intestines, it's really quite slow in the first 6 months of life. And because it's quite slow, any medicines that are absorbed in the GI tract might have slow absorption, and the best example of that is creon, so your pancreatic enzymes. The production of bile salts, so the liver produces bile salts, and that's reduced in the first 6 months of life. The bile salts help to break down the medicine or the food and absorb the fat-soluble vitamins, and so children in the first 6 months of life are particularly at risk of fat-soluble vitamin deficiency because they're not absorbing that because the bile salts aren't quite to the adult levels. In addition to all of this, vomiting and feeds after medication administration is common in young babies. I had my first experience with this last week when I was looking after my sister's newborn, and everything I gave her came back on me. With regard to distribution, so this is how the drug or the medicine is spread throughout the body. The amount of water that children have is higher than the amount adults have. When we talk about drugs, some drugs are really soluble in water and some drugs are not, okay? For the drugs that are soluble in water, they're going to spread around the body really quite well. For the drugs that aren't, we might need to use a lesser dose. The best example I have of this is the antibiotic gentamicin, which we use frequently in CF, and we use this for the treatment of infection. And little kids actually need more than big kids. Okay? In addition to the absorption and the distribution, we then have the metabolism, and metabolism is processed entirely in the liver. Now, the liver enzymes aren't completely developed in infants, and because of that, the clearance of the drug can be a little bit slower. Okay? There's a steady increase in the amount of enzymes in the liver, and so the clearance will increase as the child develops, and that'll usually be normal by about 1 year of age. And an example of this is how kids handle paracetamol. So little kids process paracetamol differently from older kids, and that changes at about 1 month of age. The final thing, and this is the thing where my PhD is largely focused, is the elimination. So how the body removes the medicine, okay? And that will depend on the age of the child. It's less for a neonate, so neonate means the first 28 days of life, and it's less for an infant up to about 2 years of age compared to an adult. We can measure this too. We can measure it 2 ways. We can collect urine for 24 hours, which is fun for nobody, or we can do a blood test and estimate it. And so we usually do the blood test and estimate it because 24 hours of urine collection is not fun. And it's higher for people with CF compared to healthy controls. So what that means is if you have CF, you clear drugs incredibly quickly, okay? They're out of your system really fast if they've got any kind of liver clearance, renal clearance, my apologies. We'll move on now to prescribing for children. Some medicines that we use safely in adults shouldn't be used in children. Now, there are always exceptions, and we always need to think about the risk versus the benefit. But a good example is the antibiotic doxycycline. Now, we commonly use doxycycline for the treatment of malaria, but it's also good for some atypical bugs in CF. The problem is that if we use doxycycline in children who are less than 8 years of age, it can cause deformities in the bone development, and it can also cause discoloration in the teeth. Now, the discoloration in the teeth is really quite a cosmetic thing, but it is permanent, so we don't want to use it if they're less than 8, if we can help it, okay? Another example might be tetracyclines. So fluoroquinolones, my apologies. So things like ciprofloxacin. Now, ciprofloxacin, if you read anything on the internet or the literature that they'll send you home with in the box, it will tell you that it can cause damage to the cartilage, and it's particularly the Achilles tendon. I don't necessarily agree with the information in the box there because the study was done in infant beagles as opposed to infant children. And so this is where the risk versus the benefit, we look and we say, okay, well, yeah, if you're an infant beagle, there is a risk that your Achilles tendon is going to be damaged. But if you've got CF, quite often the benefits of using ciprofloxacin outweigh those risks. And so we will use ciprofloxacin in children with CF, okay? So that's a good example there. Iron mixtures are another problem. They can certainly stain the teeth, and the way we usually get around that is by administering them via a straw, or if the child has a tube, we can put it down the tube. And a large number of medicines used in hospitals and paediatrics are not licensed for use in children, and when we use them outside of their proven indication, that's what we call an off-label indication. Now, you'll often be told, when you take that leaflet home, that consumer medicines information leaflet, you'll think, well, I'm not using it for any of those things, and that's what we mean. When I talked earlier about the companies that are getting concessions for registering new drugs, if they've done any studies in children, they're now being increasingly licensed for children. In my time as a hospital pharmacist, I've seen probably 4 new drugs licensed for kids with CF, and I think that's fantastic. Australia's really making headway in that. So we've had Toby Solution, which didn't exist when I started. We've now got the Toby Nebs, we've had mannitol, and we've had changes to the registration of pulmozyme that allow us to use that from birth. And so that's been great to see acknowledgement and to see those companies register those drugs and license them for use in children. And we tend to use older, more established medicines, so drugs that have been around for a long time, because we know more about their use in children. So if there's some new fandangle antibiotic, we probably will hang off for a little while and see how the adults go with it first, and then we might try it. With regards to prescribing for children, there's some information that might say it's not suitable for the child, and we might commonly use that in children, and we might commonly use it in CF, and we might commonly use it in children with CF. So your hospital pharmacy department might have developed some paediatric information leaflets for parents. I know we've certainly got a lot for cardiology patients, and I've been working with a group of pharmacists about rewriting the ones for children that have CF. But largely my belief is that children should not be denied effective treatments due to regulatory issues, and I'm very firm on that. I also believe that children shouldn't be denied treatment due to formulation difficulties, and if I can make it in a different way, I will. And if you can make friends with your hospital pharmacist, that's my best advice for today, because they're quite happy to help, and we do like being able to get into the lab and, oh, we'll crush this and we'll see if we can put it in that, and oh, does that taste okay? And we will. We'll check. With regard to prescribing for children, sometimes the dose changes if the route of administration changes. So, for example, your child might be having an antibiotic in hospital that's delivered through a drip, and then when they go home on an oral dose, we often don't need to give as much. So we might give half. Sometimes we need to give more, and that's just based on how the drug's absorbed and where it's absorbed. For anyone that has a tube, so this is a nasogastric tube, so it commonly goes in the nose and into the tummy, a nasojeginal tube, so from the nose into the beginning of the intestine, a PEG, so that's one that goes from external straight into the tummy, or a PEG, external straight into the intestine. The dose is the same as for an oral dose, because essentially it's going to the same place, so the dose doesn't change there. With regard to medication administration, which is probably the most difficult thing about working with medicines and kids, we know that a lot of medicines aren't available in the liquid form, and when there is no mixture available and the child can't swallow a tablet or a capsule, one of our alternatives is to crush the tablet. Now, there's a difference between crushing and dispersing, and some tablets like omeprazole or Asamax or Losec can only be dispersed but can't be crushed. So disperse means I'm going to pop it in water, I'm going to wait a few minutes, and it will slowly dissolve. Disperse, dissolve, same thing. Crush means that you physically have to grind it down to a powder, and then you'll add some water to that. When you're crushing a tablet and trying to give it via a feeding tube, you need to make sure it's quite fine, because it can sometimes block the tube. The things that we have the most trouble with blocking tubes are the drugs that when you crush it or you disperse it, it's got little granules in it, and quite often they sort of agglutinate together, and that's how you get the tube blockage. So we try not to crush things that have granules. If the dose is a whole or a half or a quarter of a tablet, then we don't need to worry about, make up in 5 ml, give 3.2. You just do the whole or the half or the quarter. And sometimes we might round it up. So I might get a script and somebody said, I don't know, I want 102 milligrams of ciprofloxacin, and I think, are you kidding me? 102 milligrams? How hard would you like to make the parent's life? So I'll have a look at how heavy that child is, and if it's appropriate, we might say, okay, we're going to use half a tablet, which is 125, and that's still a reasonable dose. And sometimes that's the hold up with these scripts. We get them and we think, no, you're not giving that dose. Let's make it a whole lot easier. The smaller the volume of water, the better. And the reason being, if you're trying to get 5 ml in, you might get 2 and you're still battling for the next 3. So I always try and use the smallest amount of water possible. And you can ask that, feel free. Well, they say, I'll put it in 6 ml and give 4 ml. You say, well, can I put it in 3 ml? 3 ml is usually the minimum, but the smaller the volume, the better. There are some medicines that shouldn't be crushed. And basically, if they've got an R after the brand name, that's usually a bit of a giveaway. So there's sustained release medicines, extended release, controlled release. There's some others called OROS, and I realised I forgot one off that list called modified release, or MR. The good thing is we don't use many of these kinds of drugs in kids or in CF. They tend to be heart drugs. So sometimes drugs can be a bit difficult to crush because they might have an enteric coating, like a film over the tablet. One of the ways in which we get around that is particular brands are done differently. So the best example I can think of off the top of my head is a drug called atenolol that we use for heart trouble. And one of the cheap brands has a coating and we hate that, and the other cheap brand doesn't. So we go, okay, well, we only want that one. So your pharmacist will have some idea as to whether or not there's a coating on that tablet, because peeling a coating off a tablet is not fun for anyone. So if there's a different product, we would use that. There are also some drugs that are not soluble in water, and we do encounter this in CF often. It usually is your vitamin A and your vitamin E, and particularly for vitamin A that only comes as a jelly sort of capsule, that can be quite difficult if you're giving a part dose. But in all cases, ask your pharmacist, and if they don't know, they can look this stuff up. With regard to medication administration, I believe that it's really important to explain to the child what it is and why they need it. And obviously this will vary depending on how old they are. Younger children or younger infants and children tend to be more cooperative than older children. And the earlier they can be taught to swallow a tablet or a capsule, the better, because it will make life easier for you and everyone else around you. That said, it is not easy. And how I became a pharmacist is beyond me, my poor parents. I remember being held down by 3 people just to get anything into me. So they do suggest that you can start with trying with soft jellies. So for example, snake lollies, and cut them up into little pieces. You're always telling kids to chew their food and then suddenly you're telling them to swallow it whole. So that is a little bit confusing. And using a glass of water. One of the other things we commonly use is empty gelatin capsules. Something I encourage parents to do is make that a little bit of fun, like filling them with sprinkles and teaching them if they can swallow them with sprinkles in them and things like that. Now, I'm quite happy to, I don't expect you to write all this down, so I will provide this to Anne-Marie, and she can pop it up on the CFA website so that you can access this. But there are some services out there that will help you to teach your kids to take medicines. There is a brochure from the Royal Children's Hospital called Teaching Children How to Swallow Tablets and Capsules. I actually am going to diss my own organisation here. The one that Westmead have done is brilliant, and it's much, much better than the RCH one. And unfortunately, I haven't been able to find a copy online. But Westmead have been working for a few years with some speech pathologists, and they've written a great guide on teaching kids how to get medicines. So you could certainly call their pharmacy department and ask for a copy to be mailed, but I can't find an online link. The NPS is the National Prescribing Service, and they have some really good tips about age-appropriate stages at which you would introduce certain ideas. If it's anything inhaled or nebulized, the National Asthma Council has some really good videos. There's a website called medicinesforchildren.org.uk, and I'd encourage you to look at that. And they certainly have advice based on the type of medicine, and then they've got specific medication advice. And there was a pretty funky video from the FDA in both Spanish and English with a pharmacist and a paediatrician. So I'll provide this and make it available to you. With regards to leaving medicines at childcare or school, we suggest that you use the original container because the schools will often request the dispensing label. That said, if you get, sometimes you'll get like your boxes of 5 crayon, and some pharmacists will decide they're going to stick one label and put some sticky tape around it because they're too tight to pay for another 4 labels. Ask them, say, I need each bottle label, please. Like if the creche or the school or that are saying to you, I want a label thing with instructions, just ask them. We'll also often do this if there's more than one family, or if the child is in different places. So if they're going to after school care, we can do additional supply so that you've got a stash everywhere they go and you don't need to think about moving that all the time. Bedtime logistics is a big one, and I certainly strongly advocate about not waking a sleeping child. So when the prescriber writes a script for an antibiotic and says take this every 6 hours, I think this is ridiculous. And I will usually say, okay, well, is it appropriate to take it 4 times a day? Breakfast, lunch, dinner, bed, child's time, not our time, not 6 hourly. So certainly there are very, very few cases where it is actually required that you're going to have to do it strictly 6 hourly and that you wake the child to do it. And I don't support that. With regards to giving medications by mouth, you should give the mixture or the suspension a good shake before you measure the dose because the active ingredient often settles on the bottom. Magnesium's the worst. It's kind of got this, 2 inches of sediment and then water above it. My biggest advice is don't mess with the apple puree. Apple puree is for enzymes. We had somebody at some point who said, if you just put the ciprofloxacin in the apple puree and try and get it in that way, and we had a 6-month battle with that child to then get enzymes back into them. You usually, you've established the role of the enzymes in the apple puree fairly on. If they get a taste of that Cipro in there, they can develop quite a significant aversion, and then enzymes which are essential for their nutrition, and we know about the role of nutrition and health in CF. I would not put anything other than enzymes in apple puree. Oral mixtures are typically given using an oral syringe, and they're now orange in colour across the country. You can use a medicine cup or teaspoon if you wish, but I would advise against it. Adding medicines to infant formulas is not recommended. The obvious reason is, you throw the antibiotic in the 120 ml of formula and they have 60, and how much drug have they got? If you're going to do it, you do it in a separate bottle and do it with the first 10 ml and then give the next 110 ml of formula so that you know that they've got all the medicine in. We shouldn't mix medicines with large amounts of food, and some foods, particularly vitamins and minerals, can affect medicines. The big one is the ciprofloxacin, and some of the minerals like calcium and magnesium are probably the big 2 offending agents. If possible, we should avoid using milk to administer drugs, and again, that's because the drug binds to the milk and it doesn't work as well. Sometimes it's not so much that it doesn't work as well, but it takes longer to work, okay? And if they're going from an IV to an oral drug, well, they've already got drug in their system. So I'm not going to worry too much about the giving it with food. If that's the only way you're going to get it into them, you give it. It's fine. It's still going to work. Just might mean it takes 12 hours instead of 6. Always ask what you can mix it with, and following unpleasant tasting medications with a chaser. Sometimes giving them at the side of the mouth can help as opposed to the centre of the tongue because there's less taste receptors, and blocking the nose can be a trick. With regards to liquids, sometimes large volumes can be difficult, and there might be an unpleasant taste, or it's not very stable and you've got to repeatedly go back to get more of it. Some children can also be allergic to the excipients. Most frequent thing we face in paediatrics in general is children that might be on a ketogenic diet for epilepsy or that have diabetes, and there's a lot of sugar in them. Sugar has generally been taken out of most medicines, but gluten can certainly still be a problem. Using a liquid chaser should be encouraged, and adapting adult-sized dosage forms is often necessary. So we should encourage oral administration as much as possible. Don't block your tube, and know where your tube is. Inhalation is least reliable when the infant is distressed or not cooperative, and for that reason we should use a face mask or a spacer with any metered dose inhaler, and physios are experts in these devices and probably the best people to ask. Anything that's going into the nose, and we're often using nasal sprays, I encourage them to blow their nose first, and lying the child with the head tilted back or a pillow under their shoulders can help with that sort of trickle that runs down the back of the throat to reduce that. When we talk about directing it to the midline of the nose, that's the bit in here, and that will help prevent running down the throat. And sometimes some of these devices can have quite exert a lot of pressure when you're depressing it, and they might not be suitable for young children. So I've got a lot of pictures now because I was told that pictures might help in terms of understanding and visualising these things. So this is a packet of empty gelatin capsules. You can buy these at most pharmacies and they're about $7. They're not bad for teaching kids how to take medicines, and sometimes we might take, say, a half or a quarter of a tablet and put it in the empty gelatin capsule and get them to swallow it that way. The reason being is when you've got your half a tablet, there could be a bitter taste from the residue of splitting that half, and by putting in this, you sort of protected that. A tablet crusher or container and a dose cutter can also be quite useful. I've seen these at your local $2 shop, so you don't have to spend a fortune on them at the pharmacy. With regard to common medicines used in CF, and we'll go through this in a picture-based thing, we use antibiotics to both treat and to prevent bacterial infection. CF is probably one of the few diseases where we'll use antibiotics as part of prevention. We might also use azithromycin. Now, there's a little bit of a trick with azithromycin because it is an antibiotic, but we actually more often use it for inflammation. We've worked out that it dampens down quite a lot of inflammation in the lung, and that's a really good thing in CF. Sometimes, not often, we will use an antifungal, and that's always to treat a fungal infection. We don't use antifungals for prevention unless we're talking about a transplant setting. Bronchodilators are drugs that open up the airways. Enzymes are sometimes called PERT, or pancreatic enzyme replacement therapy. Mucolytic clears the mucus. It tends to break it down first and then help clear it after that. We might use insulin to adjust blood sugar levels, steroids to reduce inflammation, and vitamins to treat deficiency or to supplement. And then finally, the newest class are the CFTR correctors and potentiators, and that's to correct the gene defect. So with regards to antibiotics, you might be familiar with seeing some of these. So we've got Augmentin Duo, so this is the mixture, and then we've got numerous strengths of tablets that are available. We've also got ciprofloxacin, which unfortunately only comes as a tablet. We have on occasion been able to import a mixture from the UK. So if you were having extensive difficulty giving this tablet, speak to somebody at your hospital about importing the mixture. The one thing I can say is for the cost of it, it doesn't taste much better. We'll commonly use flucloxacillin during the first 2 years of life to prevent staphylococcus infection, and that's a picture of the mixture and the capsules that are available there. Doxycycline was the one we were talking about before that might cause some damage to the teeth, and clarithromycin is one that covers some atypical bugs. Toby, it's been great to see both Toby and Toby podhaler listed in the last 4 years in Australia, because before that we were having to take the IV form and manipulate it, so I'm very grateful to Novartis for listing both of these, and I think it makes my and your lives easier. So you've got the nebules for solution, and then you've got a dry powdered inhaler device that can be used from 6 years of age. And this is what we were using before then, the old 80 milligram in 2 ml ampule. We still don't have anything for amikacin, and sometimes we might have to draw this up and put it in a nebulizer, and in that case speak to your hospital pharmacist about getting some needles and syringes, and don't be afraid to ask how to do it. You need to, if you've got 2 ml in the vial, you need to put 2 ml of air in first, or you'll never get the drug out and you'll be standing there going, what have I done wrong? But you've got to put the air in to get the fluid out. So get someone to show you. We've got lots of demos. We're quite happy to teach. Azithromycin is the one here that I said we use more often as a anti-inflammatory than an antibiotic. Antifungals, the two antifungals that we would use most often in CF are itraconazole, which is the pink and blue one on the left, and voriconazole. Now, itraconazole's got some very specific administration techniques around food. It needs to be given with a really high-fat meal. Fish and chips is great. And if your pharmacist ever tells your child to take it with Coke or orange juice every time they have it, please don't hate us. But you get such better levels if you have it with something acidic. So Coke and orange juice is the best thing to have this drug with. Bronchodilators, we would use something like salbutamol. On rare occasions, people don't respond well to salbutamol, and we might use this one called ipratropium or Atrovent. We don't use it as often in CF because it can be quite drying, and we don't want to dry that mucus up too much and then have them not be able to expectorate it. Enzymes are probably the one you're most familiar with. Now, there's a really good reason there's no picture of the 25,000 there, and it's currently out of stock, so we are doing all we can to get those into the country for everyone. So you might get changed in recent months. Mucolytics are things that help draw water into the airway and then help cough up some of that mucus. So Hypercel is probably one of the most common ones, and then Pulmozyme works in a similar way. What Pulmozyme does is it breaks down the excess DNA in the mucus and then helps it to be expectorated, and that's why Pulmozyme is a whole lot more expensive than Hypercel. They both work incredibly well, and they are both nebulized. More recently, we've had Bronchitol listed. Now, Bronchitol is again only appropriate for kids over 6 years of age because it's a dry powder device, but the capsule goes into the inhaler and it's breathed in. Unfortunately, it requires inhalation of 10 capsules. It doesn't take all that long. I have been asking the company for maybe 1 or 2 big capsules, but that requires remaking this device, which I don't think they're so keen on doing, because the reason we have 10 capsules is because that capsule fits in that device, and that device is from another drug. So go figure, because it means you've got to list the device and the drug, and that costs twice as much. Steroids, we'll sometimes use them orally. More often we'll probably use intranasally, and Nasonex is a common one that we'll use for polyps or congestion. And then when we talk about nutrition, I tried to highlight, it's a little bit hard, I tried to highlight in red the ones that are most important to us in CF, but it's basically vitamins A, D, E and K, because these are the fat-soluble vitamins. In addition to A, D, E and K, we care a lot about zinc. The reason we care so much about zinc is if you've got a low zinc level, you don't pick up your vitamin A. Zinc's kind of the thing that goes to the mailbox and gets your mail. So it can just be sitting there for a whole long time, but if you haven't got enough zinc on board, your vitamin A level might not come up. Okay, so that's why we care a bit about zinc. You're probably very familiar with these things here. So we've got salt tablets, Vita Abdec and zinc caps. I haven't got a picture of the Aquadex, which are exported from Greece, but they're quite popular as well. Blackmores make the vitamin A. Vitamin D, there's now more brands than you could possibly imagine. And vitamin K has been a bit difficult to get in Australia in recent times, and that would only be through your hospital pharmacy. In addition to that, we might use iron tablets for iron deficiency anemia, and sometimes calcium tablets when they get a little bit older to help with bone strengthening. And then you've got your Kalydeco, which has gone to a bigger box. I don't know why. In addition to that, you've got Losex and Asimax. A little trick with Losex and Asimax. Does anyone see the logo on the bottom right-hand corner? They're identical. They're made on the same factory plant, same. There's no difference. They just put different boxes and different prices. So when you get asked if you want the generic, it makes no difference. And then next to that, we've got Nexium, which is esomeprazole. Now, the good thing about esomeprazole is it can go down a tube because it's a sachet, and the contents of that sachet dissolve quite well. So we sometimes use these for reflux. We sometimes use them because they make enzymes work better. In addition to that, we might use things for constipation or distal intestinal obstructive syndrome, and you could use anything from Movicol to lactulose to coloxyl and senna. It depends on the degree of it. We sometimes, not often, will use acetylcysteine. It does appear as an ampule or a vial, but it's not for injection, and this basically reduces the viscosity, the stickiness of everything in the gut or in the mucus to help it pass through. And we've had quite a lot of success with this. So there's not many people out there using it, but that's not a bad idea. Ursofolk is something that we frequently use for CF liver disease, and that comes as both a suspension and a capsule, and it's usually given twice a day. And then for hemoptysis, which is rare occasions where someone might cough up blood, we would use tranexamic acid, and quite often this is a really good thing to have at home if you've had any episodes of hemoptysis, to start early and then get to the hospital as soon as you can. But particularly for people in rural or regional areas, it's something that you can start before you get medical attention, and that reduces the way in which blood sort of breaks down and stops the bleeding process. Sometimes we might try something called cipraheptadine. This is actually an antihistamine, but it's really, really good at putting weight on kids with CF. So it's an appetite stimulant. I've personally had it. You'll eat yourself out of house and home. With regards to adverse drug reactions, the adverse drug reactions is the general term. So we've got allergies, which is a true allergy to a medicine. So somebody's allergic to penicillin, they have anaphylaxis. A side effect or an adverse effect, somebody has penicillin, they get diarrhea. That's something that we could reasonably expect to happen with that drug. Or they have thrush, reasonable. And an intolerance is sort of like a lesser degree of a side effect. So they'll have a little bit of a tummy upset, but they can get on with life and do things quite fine. So that's what we mean about intolerance or side effect or allergy. So a true allergy is that you should not have that again. People that have nausea or vomiting with codeine, that's a side effect and an intolerance. It's not an allergy. With regards to complementary and alternative medicines, and I'm only going to cover this briefly, but complementary medicines can cause side effects, and they do interact with over-the-counter medicines, and people don't necessarily think about them in the same way as other medicines because they're not as heavily regulated. They can certainly have benefits, but they can also have side effects, and they might interact with other medicines. So the best thing to do is talk to your healthcare professional, particularly your doctor, and consider whether or not there's any potential to interact. One thing I remember from uni is all the G's, so ginseng, garlic, what else was there? Ginkgo. They'll all make you bleed. So anything with G will increase the bleeding process and reduce the coagulation. So it's fine at a low dose, but if you're using a lot of it or you're prone to a bleeding problem, that could be an issue. One of the big ones we have trouble with is St John's wort because it interacts with some enzymes in the liver, and that can cause some significant interactions with a whole lot of other drugs. Okay. They don't go through the same testing process, and they can be sold without studies about their effectiveness. I'm not saying they don't work. I'm just saying talk to someone first and check that they're going to be okay with whatever else you're on. There is also a hotline called the NPS Medicines line, and that can be called Monday to Friday for the cost of a local call. There's doctors, pharmacists, nurses, a whole host of people that work there, and they can provide information on both prescription but also these herbal medicines. So if you've got any questions about whether or not they might be okay or appropriate, I'd advocate calling that number. With regards to where you can find information, Better Health Channel is not bad. It's certainly Australian specific, but not necessarily paediatric or CF specific. And for that reason, I want to highlight one called NHS Choices, which is a UK based one, because it is CF specific. There's also another website called Cystic Fibrosis Medicines, and I'll show you a screenshot of this briefly, and that again is CF specific. So this is Better Health Channel, which many of you have probably seen before. If you want any information on your medicines, you go A to Z of medicines and you type the medicine in there and you can pull up an information leaflet. So something like crayon. Probably the piece of paper that you threw out when you got the box. The Therapeutic Goods Administration, I wish I'd taken this out, I apologise. You can get the same information, but it's a longer way of finding it. This website is great, and it's published by a group out of Leeds, and it's called cfmedicine.com, and they've got a whole host of information on all medicines that are used in CF. They talk about why we use it, they talk about the side effects and how we give it. It's kept really simple, and it's also got some dosing advice if you want to have a look at something. I strongly advocate that. It talks a little bit about drug interactions, but it doesn't go into any detail about drug interactions with complementary medicines. But it's a really good, free, publicly available website. In addition to that, the NHS have launched this one called NHS Choices. So I went to the NHS website and I clicked on health and I clicked on cystic fibrosis, and then you can get this whole list of things here, medicines for CF. Admittedly, these are UK brands some of the time, and they might not necessarily be things we have here, but it's another good source of information. So I clicked on Toby here, and I got the following information from that. I personally love this website, and that's because it's very much paediatric based, and it's the one that's also got some stuff about, okay, you're going to give a nasal spray to a child, or you're going to try and give a nebule to a child. So you can look up by the drug, or you can look up by the type. It's just got some really great information. It's been checked, it's been peer reviewed, so they've had parents involved in reviewing this information and the process. And I think that the UK have done a great job with this. So it's medicinesforchildren.org.uk, but it's quite accessible. Again, you can search for a leaflet, so you can have a look by drug, or you can have a look by condition or disease or the type of infection. And finally, I want to thank you for your time and listening today, particularly through all my boring pharmacokinetic stuff, but I thought it's really important that you've got an understanding of why we sometimes use grossly different doses for children and how they handle things differently. So they are special and they do need our help. Thank you.